Next, we have Hassan Nassereldin presenting to us smoking cessation adjuncts are cost-effective prior to elective revascularization. This is from the group from UPMC.
Good morning. My name is Hassan. I'm one of UPMC's research scholars. Thank you for the opportunity to present my team's work. We have no disclosures. Peripheral artery disease affects more than 200 million people worldwide, 80% of which are either current or former smokers. There are a few studies that looked at the difference in postoperative outcomes between smokers and non-smokers undergoing elective revascularizations. Smokers have an increased 30-day complication rate and decreased 2-year patency and 10-year survival, thus highlighting the benefits of smoking cessation, which is a large focus of optical medical therapy. After knowing the benefits of smoking cessation, the next step is to know the benefit, if it's cost-effective or not. This has not been done yet in PAD patients. However, there are other studies in other surgical specialties. For example, this figure illustrates the cost savings associated with 5 different smoking cessation interventions for patients undergoing posterolateral lumbar fusion over different time horizons. As we can see that all 5 interventions had major cost savings at the lifetime horizon, and while looking specifically at combined interventions, we can see that over all follow-up time points, there were major cost savings. We also saw similar results in patients undergoing abdominal surgeries, where also smoking cessation was deemed cost-effective. So our hypothesis was preoperative smoking cessation therapy is cost-effective and hence should be implemented as part of the preoperative rehabilitation of patients undergoing elective revascularization. In order to test our hypothesis, we did a decision model simulating the cost-effectiveness of such therapies. Our primary analysis was a Markov state transition model. Our base case scenario was based on a VASCUP database analysis of more than 20K operations. The mean age of the cohort was 66, so we assumed our patient would be a 66-year-old patient with PAD undergoing either an elective endovascular or open revascularizations. The 5 decisions under testing are nicotine replacement therapy, varenicline, bupropion, counseling, and standard care. The sensitivity analysis done were a Monte Carlo simulation, a tornado plot, and a one-way sensitivity analysis. The following few slides will highlight the structure of our model. The first branches will be the decisions that the patient will go through. From each one of these branches, the patient has the probability of either quitting smoking or continue to smoke. Postoperatively, the patient would have the probability of the following events: having a wound, respiratory, thrombotic, or no complications, or dying. In case the patient survived, the patient would go into a Markov state for long-term follow-up. And they will go through a yearly cycle of having the probability of the following events: a myocardial infarction, stroke, graft failure, amputation, being stable with no complications, or dying. We assume that if the patient quits smoking at the short term, they continue to do so on the long term. And if they were initially smokers, they continue to smoke without transition within groups. For amputation specifically, if the patient had an amputation, we assume that there's no longer a risk for graft failure or another amputation, and they'll go into their own cycle. We have 3 categories for the model inputs: the event probabilities, which are the rate of occurrence of the events, therapies, the transitions, and the outcomes. All were extracted from published literature. And for long-term mortality, they were extracted from life tables. For the costs, we include the cost of the therapies, the post-operative complications, and the long-term medical care. All the costs were adjusted for inflation for the year of 2023. And for the yearly cycle, all costs were discounted at a rate of 3% per year. Finally, we include the utilities, which are the quality-adjusted life index for various health states. The output of our model is the incremental cost-effectiveness ratio, the ICER, which compares the smoking cessation therapies. The ICER represents the cost per quality-adjusted life year, the QALY gain, and it's usually calculated by the difference between the cost of 2 interventions divided by the effectiveness. And a commonly used threshold for cost effectiveness is the willingness to pay, where we set here at 100,000 per QALY gain, and usually an ICER below that threshold is considered cost effective. For the results of our base case scenario, standard care was the least costly and least effective, while varenicline was the most costly and most effective. In terms of cost effectiveness, both NRT and varenicline were deemed cost effective in comparison to standard care, while counseling and bupropion did not offer the same value to how much effective they were at therapies, and thus were dominated and are not the best viable options considering other alternatives. For our first sensitivity analysis, we did a Monte Carlo simulation, which is a probabilistic sensitivity analysis that allows us to run the model 1,000 times using different parameters, using preset distributions. And it allows us to visualize the change in cost effectiveness by the change in the willingness to pay. For a low willingness to pay, for example, less than $10,000, standard of care would be the most cost effective because it's the cheapest therapy. As the willingness to pay increases, we see that vernicillin becomes the most effective until it is cost effective in 82% of model iterations at a willingness to pay of $100,000 per quality gain. Bupropion and NRT were cost effective in some instances, but are not the best option in most cases, while counseling was never cost effective. For our second, how can I go back? For our second sensitivity analysis, we did a tornado diagram. This diagram allows us to visualize the impact of different parameters on the model output. And we can see that excess mortality, which is the increased mortality in smokers in comparison to non-smokers, the rate of graft failure in non-quitters, and the effectiveness of vernicillin as a therapy has been affecting the model the most. Knowing that excess mortality had the highest impact on the model, we did a one-way sensitivity analysis where we assumed equal long-term mortality rates. With this change, vernicillin is now the least costly and is still the most cost-effective, thus dominating other therapies. And this is because when more smokers survive, there are more complications which are more costly because it's cheaper to die. Smoking cessation, in conclusion, smoking cessation adjuncts are cost-effective prior to PAD interventions. Specifically, vernicillin and NRT were the most cost-effective. And considering the different model parameters and willingness to pay thresholds, vernicillin was the most cost-effective therapy. Excess mortality rates in smokers was the biggest driver of model results. Considering the impact on clinical practice, supplemented coverage for smoking cessation therapies is highly needed, and vernicillin is most likely the preferred strategy. Our limitations, we did not include the possibility for relapse. We did not include the combination of smoking cessation therapies, and we were not able to analyze endovascular and open procedures separately. Our take-home message is that initiation of smoking cessation therapies prior to revascularization is cost-effective and should be initiated for all smokers preoperatively. Thank you.
Really great work. I have two questions for you. For what constituted an elective revascularization procedure? Were they stratified by intermittent claudication versus CLTI?
So we did not determine, we can't determine what type of procedure is going. We just included the values for complications where we extracted from studies that had both populations. And in that study, it did not include CLTI, but the procedures were considered elective, like, you know, it's not emergent or urgent.
Okay, so all of these patients had intermittent claudication.
And you can say non-specific PAD.
Okay. And then my second question is, so if the patient has rest pain or is undergoing an elective procedure for CLTI or intermittent claudication for that matter, how long would you recommend waiting for smoking cessation before proceeding with revascularization? So do you initiate it right away and then go ahead and do the procedure, like prescribe varenicline or Chantix, and then do the procedure? Or do you have some sort of period of smoking cessation before you undergo revascularization?
So I'm not sure we can determine the period from this study, but we know that at least before the study, we should make sure that the patient has quit smoking. But from this study, we can't determine for how long exactly.
Please.
Whoever. Somebody asked.
Go ahead, please.
Hi, David Finley from Dartmouth. I'm actually a thoracic surgeon, so this is kind of near and dear to my heart. The big question is that there's cost savings, but it's not cost savings to the hospital, and it's not cost savings to the section. So who pays for it when you can't go to the hospital administrator and say, hey, look at how much we're going to save, but you have to pay this amount and you're not going to get any of that back?
So the cost savings are on the who's eventually paying for the procedure, for the complications, for like the long-term medical care. So it depends on what the patient's like insurance patient's status prior to the procedure. So it really depends on the situation. You can't generalize for like.
Well, but you have to have a smoking cessation program in place.
Yeah,
right? And that's a cost for the institution.
Yeah.
And most of that is not reimbursed. So you get about maybe 1.1 RVUs to see a patient for smoking cessation for a 30-minute visit, right? That doesn't pay for the provider to actually engage the patient in smoking cessation. It's not being done at the PCP level. So how do we pay for this when we know it's actually the best thing for the patient and it's going to save the entire system, like as in the US medical system, a lot of money, but you can't get your administrators to actually cough up the dough to put it in place?
Yeah, so from here, we see that we are including the costs of the therapies. So we should assume, let's say, UPMC. The UPMC is covering vernically, for example, the cost of the therapy. And knowing in return, there's less complications and we have less burden on the medical care. So it is still cost effective for the institution to go and put the therapy in place, knowing that in return, there's be less medical costs, less long-term follow-up, and less cost on the medical system in general.
Sure, in an ACO model, not in a fee-for-service model. So, thank you.
You're welcome.
Yep, very quick.
Good morning, Cassius Char from Yale New Haven. Can you tell us, very nice work, but can you tell us in your model, how did you incorporate the cost of the medications? Did you consider whether that the cost for like 1 month, 2 months, or were these lifelong medications? Because that changes a lot the costs of how much you're putting for those medications.
Yeah, so they weren't lifelong medications. So it's like a prescription prior to the operation over a set period of time.
What was that period of time?
It depends by the medication and by the study, because the costs were all extracted from published literature. I don't remember the period for each drug.
Thank you very much.
You're welcome.
Thank you.